Good afternoon, everybody. Welcome to Grand Rounds. Today, it is my pleasure to introduce Dr. Jason Cascio. Dr. Cascio received his PhD in immunology from the University of Missouri at Columbia, then moved on to Iowa City, where he attended medical school at the University of Iowa. He attended medical school at Loyola, and then did his internal medicine residency and fellowship in allergy immunology at the University of Iowa. He's been on the staff here at MGMC and McFarland since 2022, and he very kindly has accepted our invitation today to provide us with an update on the management of asthma. Please join me in welcoming Dr. Cascio.
Can you all hear me okay? Yep. All right. So I'm Jason Cascio. Nice to meet you if I've never met you before. It's impossible to cover all the updates that asthma has to offer in just an hour, so I'm going to focus mostly on therapeutic considerations because that has had rapid growth in the last 10 years or so. Really quick, just get this out of the way. I'm in 3 clinical trials. One of them has to do with asthma. That's an investigational drug not available in any other form, so I don't think it's really relevant to anything I'll talk about today. Here are the objectives. I'm going to spend just a little bit of time talking about this concept of asthma endotypes and how the immune pathways of those endotypes will contribute to airway inflammation and thus asthma. And that will kind of help us better understand the third objective when we get there. The bulk of the time is going to be talking about this concept of anti-inflammatory relievers and SMART therapy, and I'll explain what those are when I get there, and the updated GINA guidelines and how they've changed our approach to how we relieve asthma symptoms. And then at the end, we're going to go through the newer, more advanced therapies for asthma, including the biologics, and how the endotypes we're about to talk about have enabled us to personalize asthma treatment going forward. So really quickly, we're just going to spend a little bit of time on the immunology of asthma. A normal airway should look like this, a nice wide airway lumen. Air flows nice and easily back and forth to the lungs. But when you have asthma, you have airway inflammation. And so that airway just at baseline is inflamed, it's thickened. But at this state, an asthmatic patient may have no symptoms. It's only when asthma gets triggered during an asthmatic attack that you get tightening of the smooth muscles, which leads to even further restriction of that airway lumen, which then presents as shortness of breath, wheezing, coughing, and all of that. In that airway inflammation, there's a lot of things going on, and in the last 10 years or so, we've started to understand that a lot of it starts at that epithelial barrier. A lot of allergy diseases are now recognized to be an epithelial dysfunction to begin with. So in a normal intact epithelium, things that are in the airway stay in there. The airway is nice and quiet, but lots of things can disturb the integrity of that epithelial wall, and that can be viruses. So we know early exposure to viruses like RSV, rhinovirus, influenza can predispose children to developing asthma. Environmental factors, so growing up in areas that are heavily polluted, exposure to cigarette smoke will disturb that epithelial barrier. And then patients that are atopic and allergic to environmental allergens, especially those that have proteolytic activity, like DERP1 is the main allergen in dust mite, BET-V1, birch pollen, and others will actually disturb that epithelial barrier. When that happens, it leads to a big cascade of events that leads to an underlying kind of inflammatory state. We're not going to go into the nitty gritty. This is just to kind of show up here at the top at the epithelial barrier, pollutants, bacteria, viruses, and even allergens can contribute to disruption and damage of the epithelial barrier. That will activate these epithelial cells, and one of the things that they do is they have to release kind of a red alert that something is wrong, and they release these molecules called alarmins. 3 of the most well-characterized are IL-33, TSLP, and IL-25. Those alarmins are giving the underlying immune system that is surveilling the area the signal that they need to mature and initiate some kind of a response to deal with whatever is insulting the airway. Now, when it comes to the asthma, a lot of this is driven by T cells. T cells are kind of like the quarterback of the immune system. They make a lot of the decisions about what kind of response you're going to have. TH0, pictured here, this is representing a naive T cell that has never seen any kind of antigen. When it gets activated, depending on the environment that it's engulfed in at the time of activation, it can either become a Th1 or Th17 or a Th2. And that all has to do with the cytokines that the innate immune system makes. So for instance, if a T cell gets activated in the presence of IL-12, it's going to polarize into a Th1 cell that makes mostly interferon gamma. If, on the other hand, it sees a lot of IL-6 and IL-23, it's going to instead polarize to a Th17 cell, which makes a lot of IL-17. Collectively, the Th1, Th17 cells, we refer to that as type 1 immunity, or in asthma speak, sometimes we call that type 2 low, which is a little bit silly to just call it type 1. On the other hand, and this is more likely to happen in atopic individuals, if a T cell is in an environment with a lot of IL-4, it's going to polarize more so towards a Th2 cell, and these cells are going to make more IL-4, IL-5, IL-13, and kind of promote a type 2 immunity. So endotypes can get really complicated really fast, so we're just going to basically consider two. T2 high or type 2 immunity, and then T2 low or type 1 immunity. This is just a schematic. I just put this up there just to show how complicated it gets. So in the center, there's our naive T cells, lots of different combinations of signals it can get to decide how it's going to differentiate. Down here, you've got TGF-beta, IL-6, IL-12, promoting Th1 and Th17 cells. That's going to form that T2 low or type 1 inflammation, which is really dominated by neutrophils. So neutrophilic inflammation associated with type 1 responses, as opposed to type 2 inflammation, which is going to make IL-4, 13, IL-5, and that's going to promote more of an eosinophilic inflammation. And there's implications for how well we can treat asthma depending on the endotype that they are presenting with. A lot of focus over the last 10 years has been on type 2 inflammation because that's the majority of patients we see. This is the classic eosinophilic or allergic asthma. In the center here is a eosinophil, and on the left side of this graph are all the ways that it contributes to airway hyperresponsiveness. So it secretes cytokines that will activate epithelial cells, that cause smooth muscle cell contraction, and promote mast cell activation and survival, which leads to more IgE responses and histamine release. And then it also further promotes more Th2 cells to further perpetuate this. On the right side, it also contributes to airway remodeling with constant asthmatic inflammation by promoting extracellular matrix production, fibroblast activation, proliferation, and thickening of the smooth airway muscles. This is the last graph I'm going to spend on endotypes, and this is just kind of to simplify it a little bit so that we can kind of understand the basic nuts and bolts of what we know drive this. So again, at the very top, at the epithelial border, viruses, microbes, allergens, air pollution, what have you, induces the epithelial cells to release alarmins like TSLP. That's going to activate the immune response. If the immune response sees IL-4, it's going to polarize to a type 2 phenotype, which is going to make more IL-4, IL-5, IL-13, which is going to promote more of that allergic phenotype with eosinophils, mast cells, and histamine release. As opposed to the type 1 neutrophilic asthma, which is more Th17 cells and not pictured here, Th1 cells, that leads to neutrophilic asthma. The symptoms are very much the same: airway remodeling, mucus hypersecretion, asthma. But type 2 allergic asthma is pretty responsive to steroids. Type 1 neutrophilic asthma is more insensitive to steroids and much more difficult to treat. And unfortunately, we have not that many options specifically targeting type 1 asthma, but that is changing. I don't have a great way to transition to the next part. All right, so now we're going to launch into the second objective, which is to talk about some change in the way that we approach therapy for asthma in terms of inhalers and how the GINA guidelines have changed recently. So the traditional approach to, first of all, let me say that the majority of asthma patients that we see are classified as intermittent or mild asthma. There are moderate and severe asthmatics, but the majority are mild. And the traditional approach to asthma for years has been, if you have asthma, we're going to start you off with just a short-acting beta agonist or bronchodilator like albuterol and see how it goes. However, we now know that we tend to over-rely way too much on medicines like albuterol or short-acting bronchodilators for asthma relief. For one thing, patients tend to see this as their primary treatment and they rely just on that. And when they really need a daily controller medication, because they're getting the relief from the albuterol, they don't get that in daily controller soon enough. And then because it's albuterol typically gives you fast relief, patients tend to stick to that and are inconsistent with their use of daily controller inhalers because it doesn't give them that same instant gratification that the albuterol does. Using albuterol alone as a rescue therapy is fraught with some pitfalls that we now know more and more about. So like I said, we tend to over-rely on it, which delays the more needed medications of daily controllers. But we also tend to not escalate care when we really should. So the expert panel reports the latest is the EPR4, but the EPR3 categorize things as follows. So this is just a simplification of how we decide if asthma is controlled or not. And I didn't put all the factors, but these are the most important ones. So what I wonder if everybody realizes is that albuterol use is one of the number one things we can ask patients, basically how frequently are you using albuterol, and that will tell us how well it's controlled. And it doesn't take much. If they're using it more than twice per week, they are not well controlled. So a well-controlled asthmatic will ideally need it less than twice per week. Nighttime awakenings are important. So for children up to 11 years old, if they're having more than one nighttime awakening from their asthma per month, they are not doing well. And it's basically the same for 12 and up, but it gives us some more leeway, 1 to 3 per week. And then exacerbations of asthma that require an oral steroid is one of the most underutilized methods to know if you're not well controlled. If you have more than one course of oral steroid per year for asthma, you are not well controlled. And I see lots of patients that end up in my clinic for evaluation of their asthma where they've gotten 3 or 4 or 5 courses of steroids over the course of months, let alone a year. And that's important because if any of these things on the right are true, if they're needing their albuterol more than twice a week, or they've gotten more than one steroid course in the past 12 months, we need to escalate therapy. We can't just rely on albuterol, but unfortunately, a lot of times steroids are thrown at it, symptoms get better, but we don't change the albuterol approach. Oral steroid use is not benign. Just 4 to 5 lifetime courses of an oral steroid increases cumulative risk of osteoporosis, diabetes, cataracts, heart failure, pneumonia, and other complications. So we really need to control asthma through inhalers and rely less on oral steroids. I'm just putting in here a graph from the updated GINA guidelines. I blacked out step 1 because I don't want to have any spoilers yet for what I'm about to get to. But this just kind of shows you the steps you should take in terms of adding on daily controller inhalers for asthma. So if they're just using albuterol alone and any of the things on the right side are true, you should step up to the next step, which is to add a low-dose maintenance inhaler, containing an inhaled corticosteroid. If they're already on step 2 and they're not well controlled, go to a low-dose ICS LABA. These are things like Advair, Symbicort, Dulera. And then from there, you go to a medium dose or a high dose if they're not controlled. And then step 5, you're going to more advanced therapies, which I'll get to in a little bit. So again, we're relying too much on albuterol as a asthma treatment. Again, patients are tending to regard their albuterol as their primary asthma treatment because it gives them instant gratification, but they're overusing it. The important thing to know and to express to patients is that albuterol will treat the symptoms. It will bronchodilate them, but it does not address the underlying inflammation that is causing these symptoms. We also know that overuse of albuterol, not only are we not getting asthma controlled, but it's associated with poor outcomes. So overusing albuterol, and it doesn't take much, just 1 or 2 days of continuous, like every 4-hour albuterol use will lead to a reduced bronchodilator effect. The smooth muscles start to downregulate those beta receptors, and you get a tachyphylaxis kind of thing, which leads to a vicious cycle of now they need their albuterol more often because it's not working as well or not lasting as long. And then after just 1 or 2 weeks of using albuterol fairly regularly, that will actually increase their airway hyperreactivity. It increases their allergic response. It increases eosinophil recruitment to the airway wall. And it's associated with an increased risk of asthma exacerbation and death. So if we're just giving them albuterol over and over again, we're actually doing them a disservice and putting them at risk for poor outcomes. And then bringing this schematic back again, an asthmatic airway has this underlying inflammation in the airway wall. If they have an attack and we give them albuterol, we relax these tight and smooth muscles, but we do not address this underlying inflammation. A patient with this kind of underlying inflammation may feel completely fine. They may blow a completely normal pulmonary function test, but that inflammation is still there. So that brings us to the concept now of anti-inflammatory relievers, which is a more recent change in the way that we're treating asthma. So now we recommend, instead of using albuterol as needed, the optimal approach is to use an inhaled corticosteroid with formoterol as needed, essentially Symbicort. And this all came from this New England Journal article from 2018, where they asked the question, who would do better, patients doing essentially albuterol as needed or patients that do budesonide formoterol as needed? The reason they picked formoterol is because although formoterol is a long-acting beta agonist, it has a rapid onset of action similar to albuterol. So onset of action for formoterol is 3 minutes and reaches 80% of its peak effect within 15 minutes, yet its duration is still long, 12 hours. As opposed to other long-acting beta agonists like salmeterol, which is the one in Advair, that has an onset of action 30 to 48 minutes, doesn't reach peak effect for 2 hours. So this would not be an ideal option for rescue therapy, but formoterol is. This is from 2006, just showing the proof of principle of this. They would do a methacholine challenge test to instigate bronchospasm. And then this is looking at a score that measures breathlessness, essentially. At baseline, they're there. Oh, we made you feel like crap. And then if they give budesonide formoterol or a short-acting beta agonist, they have relief of symptoms just as quickly compared to placebo. Same thing is seen with improvement in their FEV1 on pulmonary function testing. Methacholine is given, their FEV1 drops. Whether you give Symbicort or a short-acting beta agonist, they have a similar return of their FEV1 numbers afterwards compared to placebo. So formoterol can be used as a rescue bronchodilator. So in this paper, here was the setup. In this case, they used the terbutaline as their short-acting bronchodilator, and they randomized patients into 3 groups. One group got a placebo controller inhaler plus short-acting bronchodilator as needed. Traditional approach of just albuterol as needed. Second group got a placebo controller plus we're told to use budesonide formoterol as needed. And then the third group had the short-acting beta agonist, but they were on a daily ICS controller. And then they followed them for 52 weeks. And what they found, so the blue line, this is the short-acting bronchodilator only. They had a much higher probability of developing a severe asthma exacerbation compared to those who used the ICS formoterol as needed. And the ICS formoterol as needed did just as well as patients that were getting a steroid daily in terms of exacerbation. And the same was true if you combined both moderate and severe exacerbations. The short-acting bronchodilator alone did much worse. And then they eventually did a couple of different meta-analyses. This is looking at as needed ICS long-acting beta agonist versus just PRN short-acting beta agonist. And what you can see is that all the studies and the overall fell to the left of this line, which favors using a PRN ICS bronchodilator approach over just a traditional approach. This is looking at exacerbations requiring systemic steroids. They also did a similar analysis looking at the same question, but now comparing just to as needed ICS LABA compared to doing a daily steroid controller. 2 of the studies actually favored the PRN basis. So don't do anything daily, just do as needed ICS LABA. 2 of the studies were right on the line. The overall effect just crossed the line of 1, so can't quite say it's significant, but similar results whether you're doing ICS LABA as needed versus doing something daily. So because of that study, the use of an anti-inflammatory reliever is now what is recommended by the international guidelines, the GINA guidelines. These guidelines say avoid albuterol as your only therapy for reliever, and this applies starting at age 4 through adulthood. So here's the 2024 update, GINA update for asthma. The preferred track is at steps 1 and 2, you just do as needed, low dose ICS for Formoterol, brand name Symbicort or the generic budesonide for Formoterol is what's typically used. And then if that is not controlled, so they're needing that more than twice per week or they're having more than one steroid course in a week, step 3 is then you go on and add the controller. Same medicine, low dose ICS for Formoterol, but you still use the same low dose ICS for Formoterol as your reliever. This combination is what's called SMART therapy, so single maintenance and reliever therapy. You have one inhaler that does both. And then you follow the steps the same as it's always been. After that, you go to a medium dose if not well controlled and so forth. The alternative, because there's problems with this, not everybody's insurance will let them have Symbicort or Breyna or the generic. And so if you can't get that, the recommendation is go ahead and just stick with traditional albuterol, but prescribe an inhaled corticosteroid along with it that they should take every time they take the albuterol. So that would be Asthmanex, Qvar, Pulmicort, something like that. Step 2 is then you go to the maintenance inhaled corticosteroid, but then the same, anytime they need a reliever, they should take an extra dose of that, or you get them the combination inhalers and so forth. So budesonide for Formoterol, this is what's recommended in the guidelines. That's brand name Symbicort or Breyna. Some people wonder, wow, I'm taking a lot of doses of my Symbicort, is that okay? For 12 and up, they're actually allowed 12 inhalations per day. And standard daily controller is 2 puffs twice a day, so that leaves 8 additional puffs they can take throughout the day as a rescue. For 4 to 11, they're allowed 8 inhalations per day. Dulera is another daily controller ICS LABA that also has Formoterol, but the steroid is different, mometasone. This should work in theory, but it was never studied, but it should work in theory. Now, there's lots of barriers to this. The FDA, despite these recommendations, has not approved any ICS LABA combination, including Symbicort, et cetera, as a reliever device. And so that runs into some insurance coverage problems. First of all, ICS for Formoterol may not be the preferred ICS LABA from the insurance. They might want Advair instead, and that doesn't work the same way this does. Or maybe they cover Symbicort, but because they're using it as a reliever, they're running out of it before the 30-day point, and so insurance won't let them have a new one until they reach there. So they're running out of it. So insurance hurdles are the biggest obstacle to this. The other big obstacle is just changing habits. We're just kind of in the habit of albuterol as needed. You're doing well, continue albuterol as needed. Changing things around has been difficult. One way we've kind of broken through this barrier is there is a new inhaler that was approved in January 2023 by the FDA called AirSupra. This is albuterol with budesonide. So it's kind of like Symbicort, except it has a short-acting bronchodilator instead of the long-acting Formoterol. And that was approved in January of 23 by the FDA to be used as an add-on reliever for patients already on a daily maintenance inhaler. So this was kind of the industry's response to the lack of FDA approval. This has also had obstacles because not all insurance covers it. Despite being approved for 2.5 years now, I tried to prescribe this just earlier this morning and it wasn't covered by insurance. So insurance coverage is improving, but many still don't cover it or are making us go through these prior authorizations to get it. Here's the data on AirSupra. So the first data came out in 2022 in the New England Journal. This was looking at 2 different doses of AirSupra in patients who were already on a maintenance inhaler. And what they found was with the higher dose combination, which is doing basically 2 puffs AirSupra as your rescue, the hazard ratio of having an exacerbation was 0.74, or in other words, 26% reduced risk of severe exacerbation compared to just using albuterol alone. And then they just came out about a month ago with a study also in New England Journal looking at the same inhaler now in mild asthma. So in these patients, 74% of them were just using albuterol. They were not on a daily controller. And similar findings, probability of severe exacerbation was much higher on patients using albuterol alone compared to those who got the extra hit of steroid every time they used their rescue therapy. And then this is from the same study. So the number of first exacerbations in the group that got the albuterol budesonide was only 83 patients compared to 160 in the albuterol alone. And the patients that got the albuterol budesonide also had a lower exposure to systemic steroids per year compared to the group that got albuterol alone. However, the FDA approval for this is still only as an add-on therapy to patients already on a daily inhaler, but this article that just came out suggests that this should work as their reliever monotherapy for mild intermittent asthma. So in summary of this part, overuse of albuterol or short-acting bronchodilators increases risk of asthma exacerbation and death. If they're using their albuterol more than twice per week, they really need to be on a daily controller inhaler. And anyway, it's no longer recommended to use albuterol or levoalbuterol alone as an asthma reliever. Ideally, ICS formoterol should be their as-needed medicine for both steps 1 and 2 of the GINA guidelines, but in the absence of that, at least using AirSupra if we can get it, or using a ICS every time they use their albuterol. SMART therapy is now recommended by GINA. Again, that's single maintenance and reliever therapy starting at step 3. So if they reach step 3, they should be doing their ICS formoterol, and then as needed, more ICS formoterol. And then again, AirSupra is the only FDA-approved option approved for this at the moment. Insurance coverage is still pretty spotty. All right, we're going to launch into the last objective here. And this is going to look at the biologics, the advanced therapies we now have for asthma. And this is going to bring those endotypes back into the picture and kind of show you how we personalize our treatment approach. So we're going to go back to this graph. So I kind of showed you how you can get T2 high asthma versus T2 low asthma. There are signaling molecules that are kind of responsible for shifting things in one direction or the other. Again, the first signal we get are from the alarmins, and I'm going to talk in a little bit about a biologic we have that targets TSLP. Most of our biologics, unfortunately, are all in the T2 realm. The TSLP biologic is the only one that has the potential to help neutrophilic asthma. IL-4, again, is that first signal that pushes things towards the Th2 phenotype, and then those Th2 cells make more IL-4, IL-13, which is going to promote mast cells, histamine production. They make IL-5, which makes eosinophils. So in theory, if you can disrupt these signals at these different points in the process, you might be able to disrupt this inflammatory cascade. So the first biologic for asthma that we got was back in 2003, so 22 years ago, and that was omalizumab or Xolair, which is a monoclonal antibody that binds to free-floating IgE in the bloodstream. And then it wasn't until 12 years later that we got another biologic available. The first one was after omalizumab was mepolizumab or Nucala. Here we started really getting into IL-5. Remember, IL-5 is that signal that promotes eosinophil recruitment and survival. So we started targeting IL-5. A year later, March 2016, reslizumab or Cincar came in, another IL-5 antagonist. And then a year later, benralizumab or Fasenra, yet another IL-5 antagonist. October 18, we finally moved away from IL-5 and we got Dupixent, which you've probably seen lots of commercials for because it treats everything. It targets both IL-4 and IL-13. And then finally, we got to the TSLP antagonist Tezspire in December of 2021. So I'm going to spend the next section kind of going through these biologics, what they do, how they work, and how they help asthma. So I'm not going to spend a lot of time on Xolair just because we don't use it very often anymore, but here's a depiction of a mast cell. The way mast cells release histamine is they have receptors on their surface that bind to allergen-specific IgE. When then you encounter an allergen, that cross-links that IgE and leads to degranulation and histamine release. Xolair, the way it works, or omalizumab, is it blocks and inhibits the free-floating IgE, which in turn makes less IgE available for mast cells to grab onto. Mast cells are very efficient. They say there's no IgE. We're going to downregulate those receptors, and as a result, they are less likely to degranulate and less likely to release their histamine and other inflammatory markers. I'll just briefly say that in the trials for Xolair for asthma, it did reduce exacerbations by just shy of 50% and had an 85% lower risk of asthma hospitalization. But again, we don't use it very much for asthma anymore. We mostly use it for other reasons. So again, Xolair blocks IgE, approved for moderate to severe allergic asthma. Here's where endotypes and biomarkers kind of come into play. In order to get Xolair approved for asthma, they have to have an elevated IgE greater than 30. Greater than 30 is not elevated, but it has to be at least that. And they have to have a positive allergy test to a year-round allergen, dust mite, cat, dog, something like that. If you don't have that, you can't have Xolair. It's approved for 6 and up for asthma. It was recently approved for 1 year and up for food allergy. Dose depends on weight and IgE level. And then there is an FDA black box warning on it for anaphylaxis. So regardless of why you use it, the first 3 injections are always given in clinic. All right, we're going to move on to the IL-5 antagonist now. So the first one that came out was mepolizumab. Mepolizumab is targeting IL-5, which is that growth factor that allows eosinophils to be recruited and to survive. Mepolizumab binds to and thus blocks that cytokine, and so eosinophils are deprived of that signal. The first study came out in Lancet in 2012. This was looking at IV mepolizumab at 3 different doses, and you can see there is a 52% risk reduction for asthma exacerbation compared to placebo. That was then followed up with a 2014 study looking at comparing IV mepolizumab to subcutaneous mepolizumab, and they had very similar improvement, 53% reduction in asthma exacerbation, and it improved lung function, FEV1, by 100 cc's. The subcutaneous version is now what we use. There's the FEV1 data there. So again, blocks IL-5, inhibits IL-5 signaling. It's an add-on, approved for add-on maintenance for severe eosinophilic asthma. So you have to prove to insurance that they have T2 high asthma by showing an eosinophil count at least 150, but it tends to work better the higher the eosinophils are. This is approved for 6 and up. Depending on the age, the dose can be different, but it's given every 4 weeks regardless. And side effects are fairly typical things, headache, injection site reactions, and things like that. Real quick interlude, little soapbox here. Stop prescribing Benadryl. Benadryl is a very short-acting antihistamine, has lots of side effects, sedation, cognitive impacts. Zyrtec and Allegra work just as quickly as Benadryl, last much longer, and they're not going to mess up the brain. Even if you give Benadryl at night, cognitive impacts last well into the next day. Some people give Benadryl at night because they've already given Zyrtec in the morning. Just give an extra Zyrtec at night. It's perfectly fine. Stop doing Benadryl. Anyway. Thank you for my TED Talk. A year later, reslizumab came out, same mechanism, blocks IL-5, similar risk reduction for asthma exacerbations compared to mepolizumab. It did improve FEV1 better than mepolizumab. What's unique about this one is this is an IV medication that is used with weight-based dosing. So it's really helpful, say you've got your morbidly obese patient and you're worried the subcutaneous mepolizumab is just not getting enough drug delivery. You can use the IV version directly to the bloodstream, and it's based on weight. Same mechanism, I'll just kind of speed through this. For severe eosinophilic asthma, got to have that eosinophil count. Only for adults, though. Dose is 3 mg per kg IV every 4 weeks. Oral pharyngeal pain and hypersensitivity reactions are the biggest side effects. Benralizumab came out a year later. This is another IL-5 antagonist, but it works slightly differently. So instead of blocking the cytokine, it actually blocks the receptor on the eosinophil. Practically, it has the same effect. The IL-5 can no longer activate the eosinophil, but it also has an additional effect. I'm going to bring you back to your med school immunology. It induces natural killer cell mediated eosinophil apoptosis via antibody-dependent cell-mediated cytotoxicity. So if you remember from your basic immunology, if you have a cell, in this case the eosinophil, and it has an antibody bound to its surface, so here's Fasenra binding to the IL-5 receptor, natural killer cells have an Fc gamma receptor that will recognize that antibody bound to the cell, and that will activate the natural killer cell to kill that eosinophil. So patients on Fasenra, not only are we seeing eosinophils not be recruited, but the ones that are destroyed, and their eosinophil counts go from greater than 300 to 0. Here's the data showing that it works. So baseline, here's the annual rate of asthma exacerbation. And then with either 4-week or every 8-week dosing, exacerbation risk plummets. And then here's a change from baseline to FEV1. Both the 4-week and 8-week dosing have a big improvement in FEV1. So this is also an add-on maintenance therapy, has to have an eosinophil count greater than 150, 6 and up. Dose is 10 or 30 milligrams, depending on your age and weight. They get it every 4 weeks for 3 doses, but then afterwards it's every 8 weeks. So a lot of patients really like this one because they're not injecting themselves as often. Side effects, headache, pharyngitis, things like that. All right, now we're going to talk about Dupixent. This is the first time we're getting away from IL-5. This is a monoclonal antibody that inhibits both IL-4 and IL-13. IL-4 and IL-13 are kind of unique because they signal through the same receptor. So it's not labeled here, but this blue guy here, that's IL-4 receptor alpha-1, and this guy here is IL-13 receptor alpha-1. They will dimerize and allow signaling with both IL-4 and IL-13. Dupixent blocks just IL-4 receptor alpha, which is sufficient to prevent this dimerization and thus prevent signaling with both IL-4 and IL-13. So here's the data from 2018. We're looking at anything to the left of the line. Dupixent is better than placebo, and we're looking at exacerbation risk. And so at the 200 milligram dose, if the eosinophils are greater than 300, Dupixent was better. 150 to 300 eosinophils, it just barely crossed the line. But with the 300 milligram dose of Dupixent, 150 and up, both were Dupixent was better compared to placebo, but like the other biologics so far, if the eosinophils are less than 150, there's no difference from placebo. Here's the improvement in FEV1 with Dupixent. So it had a 300 plus increase in the FEV1 at the two different doses shown in the two colored blue lines. This is one of my favorite graphs to kind of highlight the problem with asthma therapy in general. Adherence is estimated to be about 30 to 70% when it comes to patients using their inhaler. Look at the placebo group. They weren't on any other therapy, but their FEV1 improved by 200 cc's. Why do you think that is? It's because in order to be in the trial, they actually had to record and document that they were actually taking their maintenance inhalers. So look, you just have patients start taking their maintenance inhaler every day, they get a drastic improvement in their symptoms. So adherence is key. So overall for Dupixent, the relative risk reduction for exacerbation was 46 to 48%. It jumped to 2/3 reduction if their eosinophils were greater than 300. And the FEV1 improved on average by 320 cc's. So Dupixent, again, blocks IL-4 and IL-13 signaling, add-on maintenance for moderate to severe eosinophilic asthma. It also has an indication from the FDA for steroid-dependent asthma of any severity. Have to have that eosinophil count like the others. Approved for 6+ for asthma. It's approved down to 6 months for eczema. So if you want to treat your 1-year-old with Dupixent for their asthma, just say that their eczema needs it. Initial loading dose followed by every 2-week dosing thereafter. Big side effects are injection site reactions, conjunctivitis, mostly seen in eczema patients for some reason, arthralgias, and it can cause peripheral eosinophilia. All right, so all of this so far has focused on T2 high asthma, the eosinophilic asthma. Finally, in 2021, we got Tezspire or tezepelumab, which targets that type 2 low neutrophilic asthma. It's blocking this alarmin. So it's the most upstream disruptor that we have, and in theory should block all downstream events, whether it's going to be neutrophilic or eosinophilic inflammation. That's basically what this graph tells you. Here's the data on that. So again, left to the line, tezepelumab is better than placebo, looking at exacerbations annualized. If the eosinophil count is greater than 300 or 150, tezepelumab was better. But unlike the other biologics, if the eosinophils were less than 150, tezepelumab was better. So this is the first biologic we get that is useful for patients that don't have that elevated eosinophil count. Here's the improvement in FEV1 for tezepelumab compared to placebo. So again, only biologic approved for non-eosinophilic type 1 asthma. However, its efficacy is still partially dependent on eosinophil levels. If you go into the supplemental materials of the data, you'll see that if the eosinophils are greater than 150, the exacerbation reduction is only 39% compared to up to 77% with higher eosinophil counts. The improvement in FEV1 is also highly dependent on eosinophil levels. The less than 150 eosinophils, which is really the target population for this biologic, had barely a blip in their FEV1 compared to those that had higher eosinophil counts. So this one inhibits TSLP, that alarmin. It's add-on maintenance for severe asthma. No biomarkers. You don't need them. You can get it approved. Only for 12 and up. It's given every 4 weeks. Similar side effects to all the other ones. And then I'll speed through this one real quick. Oops, skipping ahead. In 2024, a clinical trial was published in New England Journal looking at a newer biologic called depemokimab. This is an ultra long-acting IL-5 antagonist. You only give a dose every 6 months, but works similarly to mepolizumab and the other IL-5 antagonists. So here you can just see briefly, depemokimab had a better cumulative incidence of exacerbation compared to placebo. Exacerbation rates were reduced by about 50%. From last I saw, FDA approval is anticipated for December of 2025, but we'll see with all the weird stuff going on at the FDA. It's going to be an add-on for severe asthma. We'll probably need that eosinophil count to be greater than 150, probably for 12 and up. The dose is going to be every 6 months. So far, injection site reactions, headache are the biggest thing. One thing we'll have to see post-marketing, this is a long-acting biologic. So if you have a hypersensitivity reaction, it's going to be in your system for a long time. So we'll have to see how that plays out. All right. Really quickly, so how do you choose which one of these to use? So one way we consider which one to use is we look at their comorbidity. So all these biologics are approved for asthma. Xolair is also approved for chronic urticaria. It's approved for nasal polyps, and just last year got approved for food allergy. Mepolizumab is also approved for nasal polyps. It's approved for eosinophilic granulomatosis with polyangiitis, hypereosinophilic syndrome, and just last month got approval for COPD. Dupixent has the most things: eczema, nasal polyps, EoE, prurigo nodularis, COPD, and just 2 months ago got approved for chronic urticaria. So depending on the comorbidities, that might sway you one direction or the other. You also need to consider the biomarkers, like I said. So Xolair, if you're going to use that one, you got to have an elevated IgE and allergic to a year-round allergen. For Dupixent and the other IL-5 antagonists, you have to have more than 150 eosinophils. For Tezspire, no biomarkers are required. So if none of these two things are true, you're basically stuck going with Tezspire. There are no head-to-head trials comparing them to each other because they would never submit to that. However, if you compare data from individual trials, we see that Dupixent had one of the best risk reductions for exacerbations and had the best increase in FEV1 at 320 cc's. Tezspire had the best risk reduction for hospitalizations and similar exacerbation reduction compared to Dupixent, as long as eosinophils were greater than 150. Fasenra, this is the one that kills the eosinophils, had the best reduction for exacerbations, but was kind of middle of the road on all the other parameters: FEV1, hospitalizations, need for oral steroids. One group, though, tried to emulate a head-to-head trial, and they kind of did it in silico. This came out in 2023. They basically went to an integrated patient database, and they, quote-unquote, recruited patients who had severe asthma and were on a biologic, and just kind of followed them as if they were in a clinical trial, looking at whether they had exacerbations, whether there was a switch to a different biologic, things like that. And they came up with their own inclusion criteria. So they kind of simulated an in silico clinical trial. What they found, this was comparing Dupixent to mepolizumab to omalizumab. Dupixent had the best cumulative incidence of exacerbation over 360 follow-up days. And then if you include exacerbation plus a change to a different biologic as both failures, it even spread them out further. So in that case, Dupixent still did the best here in the red line. Omalizumab was second best. Mepolizumab actually did the worst, more exacerbations and switches to a different medication. They then followed it up with a second study. When the first study came out, Tezspire hadn't been released yet. They followed it up with another paper the same year with Tezspire. In this graph, you're looking on, so we'll go with the left one first. The better exacerbation reduction is on the y-axis, improvement in FEV1 on the x-axis. You can see tezepelumab and dupilumab kind of cluster up here in the right corner, which means that those two are favored compared to the others. If you compare exacerbations upward with a patient subjective questionnaire, mepolizumab did the best in terms of patient questionnaire subjectively how they were doing, but tezepelumab and dupilumab were not far behind and had the better exacerbation reduction. And then if you look at the FEV1 with patient questionnaire, again, tezepelumab and Dupixent are consistently in that upper right corner. So when I've got a patient in front of me, I think they need a biologic, I'm usually choosing either Dupixent or tezepelumab because the data just seems that they are superior. I tend to favor dupilumab for the most part just because I'm more familiar with it, I've used it longer, and it treats so many other things. I sometimes joke with my patients that we'll just add this to the Ames water supply and then we'll be good. So there we go, just under the clock there. So we talked about the endotypes, T2 high, T2 low, and the pathways. So eosinophilic asthma with T2 high, for which they are steroid responsive, and we have most of the biologics targeting there, versus T2 low, which is neutrophilic, less responsive to steroids, harder to treat. Tezspire or tezepelumab is the only biologic we have for that, but they are looking at IL-33 as a target. That's actively being studied. Several other biologics are being studied, like IL-6, which promotes Th17 cells, are being looked at. So more things may be coming in the future. Do not use albuterol alone as a reliever. We have to be giving a steroid along with the bronchodilator. The ideal situation per the GINA guidelines is to use an inhaled steroid with formoterol, but if that's not possible, at least have them take a hit of steroid with their albuterol, and if insurance covers, just go with Airsupra, which is that combination albuterol budesonide. And then finally, we talked about all the different biologics. Now, the biologics are very expensive. These are upward of $1,000 to $3,000 per dose. All of them require prior authorizations and all this hoops to jump through to get insurance to approve it. Hopefully the cost will go down, but that's going to be one of the roadblocks we're going to face moving forward, is we're not going to be able to just use these for everybody because they're so expensive. But hopefully as they're out longer, more and more things get developed, the cost will go down and it becomes more sustainable. And that's what I got. I'll take any questions you guys have. Yep.
Well, I don't need a microphone. I'm pretty loud. But what is the genetic element? Is there some people that are prone to asthma? And is there any interest in looking at the genetic element?
Yeah, there's a lot of genetic factors. So there's genetic risk factors for just being atopic in general, allergic in general, but that's not the whole picture because monozygotic twins don't always develop the same asthma. So there's lots of other things besides genetics. There's also epigenetics. So all those environmental exposures in infancy or even in utero can affect development of asthma. So what viruses you got when you were a baby or a toddler, what kind of environment were you in when you got those infections, pollution exposure, urban cities, allergen exposures, all those things can affect disposition to develop asthma. So there's partially a genetic component to it, which have been characterized, but there's a lot of other things that are, even gut microbiome is having publications about how diet and breastfed versus not breastfed and how that affects the microbiome and the tendency to develop asthma come into play. So it's a very messy mixed bag of things that's just partially explained by genetics. Yeah.
How do you test for allergens? Are you using skin testing? How much skin testing do you do for either asthma patients or other allergies?
Yeah, so we still do skin prick testing as the allergy test of choice. There's also blood testing available looking at serum IgE levels to the different allergens. I prefer the skin test because the blood test measures antibody levels. The skin test actually shows you a reaction. Asthma patients, 80% of the time, they have some kind of an allergic component to things. So if it's an asthma patient that has never had allergy testing, we recommend getting the allergy test to see if there are environmental triggers that we can mitigate. But yeah. Yep.
With long-term use, do you form antibodies to these biologics, and do they have any efficacy, a loss of efficacy if you do form antibodies against them?
Yeah, so for asthma biologics, there are not a lot of reports of it, but we know with like the rheumatology biologics, it's very common to develop antibodies. So if you do develop an antibody against an asthma biologic, it's going to stop working. I haven't seen that a lot in asthma, and that may be because a lot of these are fairly new. The rheumatologic ones have been around for a little bit longer, but I would anticipate we might start seeing that more the longer these are out. Yep.
There's higher incidence of asthma for women who deliver via C-section versus a vaginal delivery. Is there a reason for that?
And you mean the baby's born that way?
The baby, yeah.
There's some mixed data about whether that happens or not. One of the theories is that, the bacterial exposure of going through the vaginal canal might contribute to the microbiome in the lung. So in addition to the gut microbiome, there's also a lot of research into the microbiome of what's colonizing the lung and when. So that might play a role. the whole birth process leads to a lot of signaling events in the baby as it goes through that stressful time, which might provide signals to the lung parenchyma to do this or that. So that might play a role, but I don't think it's firmly established that C-section babies are definitely going to, because not all C-section babies get asthma. So there's other factors involved in it too. Yeah.
It's interesting how things have evolved from the days of titrating theophylline doses, because at the beginning of my practice, we had theophylline and inhaled bronchodilators and prednisone.
Yeah.
Period.
Yeah. Thankfully, I've never had to use theophylline in my entire career. So, I've only been one of my fellowship, 2020 to 2022. So, in the 5 years or so I've been doing this, I haven't even touched theophylline, thought about theophylline. But yeah, it's nice that we have so many tools now to help. And even just only in the 10 years, all these biologic options, these severe asthma patients were on oral steroids, just kind of dependent on them on a daily basis for a long time. And now we're able to keep them off the daily steroids and get them under control. And it's, things like Dupixent, within 1 or 2 doses, their asthma is so much better already. It works pretty fast. Yeah.
So could you talk a little bit more about adherence and how some insurance pays and some insurance doesn't, and how do the families deal with the difference in prices, and how does that affect adherence?
Well, yeah, it's a big, insurance companies are giving me a daily headache and make me want to pull my hair out. Even if their inhaler is covered and they have $0 copay, adherence is an issue just because the daily inhaler doesn't give them that instant gratification. If they're feeling well, they tend to stop using it for a while. And so one of the things I stress to them is that those maintenance inhalers are maintenance inhalers. If you're feeling great, you still got to use it. I kind of talk to them about, I use the analogy of the inflammation in your airways as a forest fire. You can't just pour water on it, see the fires go out and then walk away. You got to keep tending it and maintaining it. And that seems to get through them pretty well, but there's still, adherence is an issue. I know I don't take my blood pressure medicine every day, so I understand how hard it is to remember to take something every day. But with something needs to be done with the insurance companies and the inhalers, because even if they are covered, they're often too much out of pocket. They can't afford them. 3 of the major manufacturers, so AstraZeneca, Boehringer Ingelheim, and GSK, have coupons available online that will cap the price at $35 for these inhalers, but it doesn't apply to Medicare and Medicaid. And that's usually the patients that are struggling to afford it. I've utilized Mark Cuban, the former owner of the Dallas Mavericks, has his own pharmacy called Cost Plus Drugs. He offers Advair for just $60. So I point a lot of patients that direction. Even patients that have insurance coverage, that's usually cheaper than their copay. So we get a lot of drugs that way too. But they only have Advair right now. They don't have other options. So if Advair is not appropriate, then you're kind of stuck. Or if they're not computer literate, because you have to go online and register with their website, you're kind of stuck. Yep.
There is a question online. It says, should you treat exercise bronchospasm the same way with steroid and bronchodilator?
Well, so what I do is, if you're treating exercise-induced bronchospasm, like you have symptoms and you're going to relieve them, then yes. But for patients that have exercise-induced asthma and they want to take a preventative, like before they run dose, I usually, if they just have albuterol, I'll have them just do the albuterol. I'm okay not doing the steroid. But more and more, I'm transitioning patients to Air Supra, the albuterol budesonide. And if they have that, then yeah, they're getting the extra steroid there. Yep.
This person, my question, based on the genetic factors of asthma, how does something like alpha-1 antitrypsin deficiency play into like an asthma diagnosis?
Well, so alpha-1 antitrypsin deficiency will lead to, damage in the airways, the alveolar wall. And so that will, eventually we think more of that with COPD, especially early onset COPD or COPD without a smoking history. But COPD and asthma are both obstructive pulmonary diseases. The only difference is the C in COPD, it's chronic. It doesn't reverse with albuterol. So having alpha-1 antitrypsin deficiency, you're going to be more susceptible to that epithelial integrity dysfunction, airway damage from things like pollutants, cigarette smoke, than somebody without. And so potentially, if you're already predisposed to asthma or atopic, you might be more likely to develop it.
Decline.
Thank you.